Okay, well, we'd like to describe child disability and HIV in a two-country study that we have been conducting together with a team. Sarah Skeen from Stellenbosch is on the line, and Mark Tomlinson and a group from UCL. Next. Essentially, this is the community care study, and a study of just under 1,000 children aged 4 to 13 years old, together with their carers. And the way we conducted the studies was we recruited 11 funding partners who fund programs in the community-based organizations, and we used their programs in order to recruit children. So in contrast to the previous speaker, our children are already attending a community-based organization, and this is not general population data, so it might be somewhat skewed. Basically, they provided us with all their CBOs, which was 588, and we stratified these and randomly selected 28, 24 in South Africa and 4 in Malawi, weighted according to population. And we sent data collectors out to gather data on consecutive attenders, and we tracked demographics and psychosocial situation of children, looking at things like quality of life and strengths and difficulties. We looked at developmental disability using a carer report measures, 10 questions, and the measure is under development, and at follow-up we used a more enhanced measure. And we also did direct testing on the children, where we had a cognitive draw person test and a working memory test, which was the digit span. And we logged school performance and created an index, which comprised enrollment in school, but that's not enough. A child has to not only enroll, but be in the correct class for their age. We looked at attendance, because you could be in the correct class but not go, and then, of course, performance. And we had data from both the child and the caregivers, as well as the organization. Next. So this just gives you a view of the overall study. These are the overall children, and you can see quite a lot of poverty indicators. 3/4 don't have their own bed. Nearly 1 in 2 is household unemployment. No one in the household is employed. Uncomfortable homes, 1/4 were food insecure. 15% lived in a shack or a sort of informal type of dwelling. But pleasingly, in these, only 4% of children were not in school. Our study was quite interested in the burden of HIV, and we were quite interested in looking at family loss, the death of a member of a family. And we found 18% had lost somebody. In addition, 11% had somebody ill in the family. Remember that you have problems not only after the death, but in the illness phases before death. And 10% had both family loss and current illness, which is quite typical of the pattern of HIV, given it clusters in families. But about 60% had none of those. Next. Then to look at our HIV positive children, within the sample, 135 children were HIV positive, which was 13% of the sample. Children were younger, they were between 4 and 13, and not all the children had status fully disclosed to them. And in addition, 189 caregivers were also HIV positive. We were quite interested not only in infected children, but what we've called affected children. And we found that 330 children lived in a household where there's somebody else with HIV. So the pie chart shows you that 66% had none of these in their world, but 9% there was a positive child, 13% positive carer, HIV positive child and a positive carer in 5%, and HIV negative child, but another positive adult in 4%. Next. So this is the results of the child development disability. It was high and in sharp contrast to the general population studies, but remember this is a somewhat skewed community-based organization attenders who are supposedly already in need. 451 had one or more type of disability, and we found no differences whether it was Malawi or South Africa. The rates are very similar, and you can see down the bar chart which kind of disabilities, and you can see some of the HIV-linked ones. For example, hearing, because you can have ear infections, motor milestones, cognitive and speech, across the board. We did find that of the 45% who had any, a quarter, 26%, only had one disability. But then you can see it ratchets up, 11% having two of the disabilities and 8% having three or more. So this multiple disability is a sort of an additional burden that we need to be looking at. Next. What about disability by HIV status? Can we say that in Africa today, HIV might be driving some of the disability fears? Well, we have clear evidence of that. All significant differences. If we compare our non-positive to our positive children, we can see that across all domains, the positive children had significantly more disability. Next. What about HIV affected and non-affected children? This is a group of children where we have the infected child, but the affected as well as the non-affected. And again, this is a significant finding. Although the positive children have the highest rate, 70%, the affected children have an elevated rate. So maybe these are negative children who were exposed in utero, and there's a literature that they might have some form of disability, or maybe just living in the house with HIV makes for problems. So the non-affected child, 39%. Next. Disability in children living in bereaved and or sick families. So if you remember my slide on the distribution of children where there had been death in the family or sickness in the family, interestingly, loss of family and sickness is fairly similar, but if they had both, a double burden, it was elevated, and if there was neither loss nor sickness, the rates were significantly lower. Next. So if we put all these variables into an analysis in a multivariate model, adjusting for a variety of background factors, what were the predictors of disability? And we found HIV infection was a significant predictor, living in South Africa, family sickness, and poor housing conditions. So very similar to some of the previous issues of clustering. What about other developmental outcomes? HIV-positive children with significantly greater emotional and behavioral problems, significantly lower health-related quality of life, and significantly worse on all the school measures. I've broken those down where you can see them basically much more likely to be in the incorrect class, to be slow learners, to struggle in class, and to attend less regularly. Next. Then looking at the measures that we actually took from the children rather than reporting, we see the very same pattern. They performed lower at the digit span and the draw person test. But I would tell you, as we're going through all these results, not all the positive children had problems, and so it's important that we don't go away with the view that all HIV positive children do have this disability indicators. Next. The impacts of HIV and development disability might be worth looking at, the double burden. The lowest performance in digit span were for the children who had double burden, and the group with no HIV nor disability scored near the mean, which is the Wechsler means, which are Western means. So really, these children in fairly poverty-stricken circumstances, high amount going to school, with no impediments of disease and disability, really are making it towards the norms. So a real call for provision and services, not only for disability, but especially for double burden. Next. Now, in our data, we were lucky enough to be able to repeat and go back to the children a year later. We were quite interested in looking at the effect of the CBO input on the children, but I've taken out some of the disability data for you. We had a good response rate, about 86%. But important to look at who were the children lost to follow-up, who were that sort of 14, 15% who we didn't get. And they were the more disadvantaged. They lived in informal shacks. They were of the 4%, they were more significantly likely to not attend school, higher mental health and higher stigma scores. So be very cautious, although we've got a very good response rate, that there is a loss to follow up on the most difficult to reach children. Next. So at follow-up, we had an enhanced measure, which not only gave you the disability components, but gave us a severity measure. The severity measure is quite interesting because this shows you the children who can't do it all, who have a lot of difficulty, who have some difficulty, and have no difficulty. And I think this is quite reassuring because really it's only the tip of the iceberg who can't do it at all. There are children with a lot of difficulty, but for the most part, children have some difficulty, and that bodes really well for interventions because in terms of children who are really disabled, in terms of not being able to do anything, service provision must be very tailored and very high level. But for children who are just having some difficulty, having something at the community level is really possible. Next. What about HIV at follow-up? Well, interestingly, at follow-up, although the differences were there, it was not significant. HIV-positive children were more likely to suffer from multiple disabilities, but some of the differences seem to have gone away. Next. What was the predictors of disability at follow-up? So as I said, HIV status now wasn't significant. Gender was, and again referring to the first talk, higher in boys, higher with unemployment, and higher with food insecurity and bereavement. So what we're seeing here is a kind of compounding effects of poverty. Next. We were quite interested in access to support grants. In our children from Malawi, no one seemed to have any access to financial support. But for the 450 children in South Africa with a disability, any degree, we did find some child support grant coverage. And of the 120 children with severe disability, again, we found quite good support grant. So it seems that children with severe disability were more likely to receive a foster care grant than those with a mild or no disability. Next. And this is access to any child grant. Remember that some of the children would get more than one. And what we do find is that a few children had 2 grants, very few, under 5%. And about 14% of children who had a disability had no access to support at all, which is a real worry. Next. What about HIV and access to grants? Of the HIV-positive children, 55% received a child grant, 26% a foster grant, and 12% a care dependency grant. And again, you can see the difference. This is quite significant, where the HIV-positive children were more likely to get 2 grants, but slightly less on 1 and pretty equal on no grants. Next. So what about uptake of service? Remember, our study was done in a CBO where hopefully there would be a portal of services for the children who'd be able to turn to their needs. And you can see from the graphs, the ones marked with an asterisk were significantly different, but it's quite a mixed pattern there, where somehow the HIV-positive children tended to get much more referral to the sort of formal medical and psychological services, whereas the education might be what they needed, but they were less likely to get it. Very low referrals and assistance rates. And the graph on the right in green shows no disability with moderate or severe disability, and it's pretty even. There's only 2 significant differences, where children were more likely to be referred if they didn't have a disability, and more likely to get medical assistance if they did not have a disability. So somehow a pattern emerging of a smattering of services available, but incoherent or incomplete targeting, and those who probably need it most probably getting least referrals. Next. So this just looks at the CBOs themselves, whether they had a policy of disability inclusion and whether they had services for disability rehabilitation. And here you can see that it's roughly half across the board. The children with any disability or severe disability have a kind of a 1 in 2, or any disability, it's a 38–61% chance of attending a CBO with a policy on disability, and very similar in terms of attending with services. So it's moving, it's growing, and there are policies out there, and remember, it's a totally random sample of functional CBOs, and there are services, but they're not permeating to all of those in need. Next. So conclusions really from our very detailed study is that the disability level is high, compounded by HIV and the ramifications of HIV. Not all HIV-positive children receive support. Children in need get more medical and psychological support, but not educational input, which is really where the major needs are. And especially there's good school uptake. CBOs are a good source of support, but they need universal policies and universal services, perhaps an advanced understanding and provision for children with HIV and children with disability, and with double burden children, and perhaps a little bit more accurate targeting of services to need. Next. Okay, thank you. This is just some drawings from our children, and also that our senior researcher, Sarah Skeen, is also on the line, so she will help with taking any questions. Sarah, do you want to have a first shot at some of the questions?
Sure. So the first one I've got here is how did the study measure the time span for these disabilities? I'm not sure I completely understand. Does that mean if it looked at when the disability develops, or what? Maybe we can have some clarity about that one. I'll move on.
Did the person that gave this question want to explain and expand a bit?
But in a way, this is a cross-sectional study. So we looked at the disability at present. So the measure doesn't tell you whether it's from birth or whether it's a recent disability. Okay. We move to the next question, which is the...
Move to the next question.
Okay, Sarah, do you want to have a look at that one?
Sure, but I'm actually thinking you're probably better placed to answer it. Partner CBOs working with children living with HIV have expressed the challenge carers face with disclosure of HIV status to children. Consequently, children have no idea what drugs they're taking and why. Any experiences of how to support carers in facilitating disclosure to promote adherence? Lorraine, I think you would be best placed to answer that one.
Well, essentially we agree absolutely, and there's a whole lot of studies that have looked at it. The WHO have published very good guidance on disclosure, and there's a growing number of studies like the work by Tamsin Rochette in South Africa and Riemann in Kenya, looking at very interesting interventions to assist with disclosure. And I know Lucy Kluver's work has shown that not being disclosed to does affect adherence. But we didn't look at adherence to drugs. Our sample was too small to pick that up. But we do agree that this is just a very important area, and maybe we should look at it in the future.
So the next question is, are you considering plans to scale up these strategies to other developing countries? And actually, our aim from the beginning was to make this into a regional study. So we've always had the hope that we could expand beyond the 2 countries that were originally involved. And we are going to be doing that. So with the support of UNICEF in Isaro in Nairobi, we're expanding the study to Zambia. And at the moment, we're right in the planning stage of doing that. So we are still selecting the community-based organizations that will be visiting. So that's happening in the next couple of months. And the developmental disability is something we're going to look at quite carefully in Zambia as well. So we're quite interested in this issue and the data that's come out of it.
Great. Any more questions, Sean?
We just got one more. I'll put it up.
Yeah. Are you considering looking at how the children will fare in the long run? Definitely, that's something that we're interested in. It just, I guess, it's a question of funding, and it takes quite a logistical undertaking to run the study in 28 different sites. So that's something we'd be very interested in, but we don't have any immediate plans at the moment. I don't know if you want to add anything, Lorraine.
No, but we do have follow-up data. So we have got baseline and follow-up, 2 data points at this point, but we would love to see it as a study with much longer follow-up in due course. Good. Well,
great. Well, thank you so much, Professor Lorraine Sherr.
So I think we have a bit more time. We do have a few more questions coming in now. I'll keep adding them.
Okay. Go ahead.
Some CBR organizations tend to become too ambitious and try to do as many things as possible in the CBR matrix. They tend to scatter themselves thin. Do you recommend CBR organizations to become more focused? That's quite an interesting question. So first of all, the kinds of organizations that we went to weren't community-based rehabilitation organizations. They were community-based organizations for children affected by HIV. So they weren't specifically looking at disability and rehabilitation issues, but mainly providing psychosocial support and referral to other services. And we have got data from these organizations about what they have been doing, and you know, as Lorraine mentioned, we have a follow-up point, and a lot of them are spreading themselves quite thin, and they're doing a lot of different activities. But I don't think that we've really found our evidence to show either way that there's one or other model that works better. So it's a bit early for us to answer that question, but that's something that we're going to be looking at now that we have our follow-up data to try and see which models work better.
Great. And we have some additional questions?
We do. Sorry, I'll let you know once they're finished. Quite a few have come in at the end here.
Okay.
Okay. Should I just keep going? Okay.
Yep.
I wonder if anyone's
Please do.
looked at, okay.
We're doing fine on time.
Sure. I'm wondering if anyone's looked at caregiver disability especially amongst elderly caregivers of overseas as a barrier to accessing services. In some DHS countries that have used the optional disability module, overall disability rate is quite high and goes up dramatically after age 40. We haven't looked specifically at disability in the carers. What we have looked at, though, actually is the older carers and trying to look and see if that has had any difference to the outcomes of the children. And actually, we found that it makes no difference at all. And we even found one measure where it was more positive if you had an older caregiver as compared to a young one. But we haven't specifically looked at disability for that group.
Sean, do we have additional questions?
Okay, there's another one. How do you address challenges of equipping centres, community early childhood development centres, with skills to effectively care and support the children? Well, I think that's really the question that we're trying to answer. So the broader study is looking at a broad range of psychosocial outcomes and tracking these children over a year of receiving some kind of community-based organisation support. So I mean, there are examples in the literature of various programs that have worked, but I think in terms of orphans as vulnerable children, there's actually very little evidence about what works. So this is something that that's really the question that we're trying to answer with this study.
Do we have additional questions? Or was that the last one?
One more, I think. Are you planning on any under 4 years early identification and intervention study? So not as a part of this study, so our age range is quite clear in the study from 4 to 13. But we do have other studies that we are working on. Actually, Lorraine and I are working on another study together, which is starting in Lesotho soon, where we will have children from the age of 1 to the age of 5. So there are other studies out there for children affected by HIV that are being run. And I'll be happy to give people details about that if they want to email me or get in touch.